All right, thank you so much for the opportunity to share some of my work with you. I have no disclosures relating to this work, and this specific paper that we have written and published was part of a larger study that we collaborated with the Department of Defense, and we developed a 7-station OSCE, and the only difference is that everyone that participated wore motion tracking sensors while doing these skills. They were all 90% of them were second and third year residents that were in the lab, and this was a skills decay study. So this is the motion tracking technology, and everyone had 3 sensors placed on both hands, one on the thumb, one on the index finger, and one on the wrist, so that we could see supination and see all of the movements. This is the fully geared up surgeon or resident, the quantified resident, and the first 5 areas where data collection were synced real time to the motion data. So the video glasses, which you see him wearing, audio, motion tracking, the camera views, both from the laparoscopic view and external view, and then separately we did the tried and true goals checklist, and then they did a self-assessment, and FPA is final product analysis, and I'll go through step by step what that entailed. But because it's a simulation, you actually get to take the skin off of the patient and look at the hernia repair and assess the quality of it. So this is the setup for the simulated operating room, and the fun thing about fabric-based tabletop sims, one, they're really inexpensive, cost about $10 to build, and 2, you can actually use all of the instruments that you normally use in the operating room except for cautery. This is a close-up view. This was someone who's gotten further along in terms of pulling up their anchoring sutures, and now they're doing their tacks. And this was the grading system. So final product analysis and the quality of the grading, we looked at everything. So this is the first 5. There was a 10-item assessment, but weighted accordingly in terms of number of steps that there were within a step or sub-steps, if you will, and you've got some weighted grading along the way. Mostly the first 5 related to the anchoring sutures, and I want to point you to where it says incorrect approach in the 2 red circles. The sutures that were pulled up there are actually really great because we placed them. So these were second and third year residents. We had no expectation that they knew how to do a hernia repair. So we actually did part of it for them and made it a little more easy. The task that they were expected to do is to grasp the tails of the remaining 2 sutures and pull them up and do the surgical planning. So the 2 that were pulled up were not tied. They were just with a hemostat. So they had to do the planning in order to see that they can get the mesh flat and all of the other requirements. So mostly the first 5 related to how they pulled up the sutures. Did they tie them, cut them in the end? Did they leave a bridge of peritoneum? And were they able to pull up the sutures in a way that the mesh ended up flat? The next step's really related to coverage of the hernia defect, and you can see in item number 7 that there's almost 50% of the defect is not covered, and so that person lost some points there. Also, just in terms of the relationship between the sutures, were they equidistant and pulled up in a similar fashion, or was it skewed? And then the amount of coverage of the mesh. So, and then the last one was really the suture to mesh. Some people planned on the outside of the abdomen where they would place their sutures, but then the mesh was smaller than that, and so you had this long strand of suture from the mesh to the abdominal wall, and we see those things. So in the end, there was a maximum of 24 points, and you could see some people got close, but missed the problem. And this one is about 10 points out of 24 where they got 4 sutures up. They tied them, but you could see they really missed coverage of the mesh. There's some wrinkling. The mesh is not flat. There's long length between the suture and the actual mesh itself. And so this person made kind of a perfect circle in terms of their planning, but they didn't really correlate that with the size of their mesh and getting things tied down appropriately. So again, this is the first study. The first thing we were really looking at was, do the motion metrics have any relationship to the final product score, the quality of the hernia repair? So this was not a study where we were looking at experience levels and comparing, junior medical students to residents or something like that. These were all second and third year residents who have had a wide range of experience with hernia repairs from 7 different programs in the Midwest, 2-year study, and they all wore the motion tracking, and we wanted to see, is there any relationship to how you're moving and what you're doing to the quality of your hernia repair? And it turns out for the motion metrics, if you look at the most common, there's a lot more, but we looked at the more common. Smoothness is a velocity metric, how quickly you're changing directions. Working volume is obviously how your hands are moving in space, in a 3-dimensional space. And path length is after you take that whole movement, every movement you make, and stretch out that signal, and you measure it. How long is it? How were you moving? And then the last one was idle time. You know, if you're pausing in between steps, we sort of calculated that metric has turned up to actually relate to decision making. When you look at what was statistically significant across the whole group of residents, it turned out to be a velocity metric and path length. And if you were more jerky and less smooth in your movements, you had lower quality scores. And if you had a long path length, you're doing lots of movements. And I'll show some of the videos of people, 1 or 2 quick videos of people that had a long path length. Quickly, our hypothesis, this is the formal one, which is a matter of record, but really what we wanted to know, now that we see that there is a correlation between all of the motion and the final score, we wondered if we could actually pick one part of the procedure and see if that actually predicted the score. And the rationale here was that, you know, when you look at time and resources, and we always used to say there's no reason to kill a pig to find out that somebody doesn't know how to use their instrument, right? So this was for us, you know, is there something that's less expensive that we could do more quickly to say whether they're even ready for this more expensive simulator and this time intensive resource of assessment? And the answer is what we found. Just pulling up the first anchoring suture, the amount of time that it takes you to pull up that first anchoring suture was significantly related to the final quality of your repair, and then your path length of your dominant hand. And then by the time you pulled up the second, and I'm talking the first tail of the first suture, then the second tail of the first suture, then everything became more significant. And so I don't need to play this video, but you can see. Oh, there we go. You can see the difference between the right and left hand. Some folks were more adept at assisting themselves, and so the path length of this person's left hand, non-dominant hand, actually is longer than their right hand, but you can see there is at least some bimanual dexterity and use of both hands. The other thing here, this is someone who has a long path length because it got some issues with depth perception, and they're not really assisting themselves. Their dominant hand is the one with the grasper. And that's a long path length. They're struggling. They're pass pointing. They're missing. They're moving in and out. And so you could see how this relates to their final repair. Some of these folks didn't finish. What was interesting, I think, when we look at some of the other stations, there was a similar correlation. You know, the tried and true suture board, which you couldn't get a chief resident to use these days, or second or third year. But when you add motion metrics to it, wow. It actually predicts your performance in a lap hernia repair. We were surprised. And it's actually the working volume. So if you aren't facile with your bimanual dexterity and your working volume on a suture board, chances are you're not going to be that way in a laparoscopic repair. Same with suturing, the start-stop nature of suturing and idle time. So there are significant correlations across the stations. And for us, in the end, I think it relates to instrument autonomy and the reality that you actually have to have some level of instrument autonomy to have a lower enough cognitive load such that then you can execute all of the other steps and do forward planning within a procedure. Again, it's the data that's the value. I think we tend to spend a lot of money on simulators, and we want them to be really realistic, but suture board, $10 ventral hernia simulator, and everyone I know, I always get this question, well, what's the cost of the motion data? It's not the $70,000, $100,000 price tag you think it is. These are some of the components. We bought 9 of those sensors, and so just with the sensors, and all of the tracking units, it's a $10 price tag. They charge you more for the software, but at least it's a one-time fee for the software. But even with this, $25,000, and you get 9 sensors of your choice, and you can then turn a quote-unquote inexpensive simulator into something that actually gets you real data and real metrics. And here's my art piece. I don't have any art. But obviously, huge opportunities to measure practicing clinicians, what we've done. I can tell you we've done a number of different procedures. When we take this to the exhibit hall of practicing physicians, whatever specialty meeting, OBGYN, surgery, anesthesia, for whatever procedure it is, they line up by the hundreds. They want the data. They think it's really cool. They want to contribute to a database of teaching and training. And then senior surgeons. There's a real opportunity here. Thank you.